Fantastic. So welcome. I'm so glad you've joined us today for this event. This is the first event for Healthcare Reinvention Collaborative, and you are joining the event titled Reinventing Healthcare. What will this take and how will you contribute? I'm Denise Weisman, and I'm joined today by my co-moderator and co-founder, Lonnie Hirsch. Lonnie and I have invited about 20 individuals to join us in conversation today. These are people who we've watched on LinkedIn courageously speaking out. They're in other forums, but they're courageously speaking about the dramatic change that we need in the healthcare system. These individuals are going to be unmuted and featured as we dive into two breakout rooms. Lonnie's going to facilitate one, I'll facilitate the others, and we're going to lead a conversation with those individuals. There are many joining us, though, for this conversation. We're going to ask that you remain off camera and unmuted, but active in the chat. So as Pontia identified, we'll be watching the chat, and we will watch for those comments that we'll want to bring up to those who are featured in the conversation. Though you're unmuted, we are welcoming you to contribute. So please, in the chat, partake. At the conclusion of the hour, everyone is invited and encouraged to stay for what we call speed networking. These are small breakout rooms that offer an opportunity to meet and broaden your network and engage in conversation. And these rooms will be somewhere between 2 to 4 people, depending on how many people can stay with us. They're 7 minutes long. It's just enough time for you to be able to connect, exchange your contact information, partake in a little bit of an extended conversation, and everybody in those breakout rooms can be unmuted and partake in the conversation. So let's talk a little bit about what this event today is. Recently, I heard Gabe Charbonneau say that we are all part of the problem. He's actually changed his, I was going to say Twitter, but his X profile to identify that he's a conspirator in the problem of healthcare. But what he's identifying is we're all part of the problem and we're all part of the solution. And Zev, who's also on this call with us today, has identified the need for us to go beyond the traditional boundaries in healthcare. He encourages us to go beyond the walls and he celebrates those who have and those who have chosen to be, as he calls them, intrapreneurs. Intrepid entrepreneurs. These are individuals that are characterized by resolute fearlessness, fortitude, and endurance. And then, of course, Don Berwick has said that we stand at the brink of a revolution in healthcare, one that demands a moral stand against a system fraught with greed, a system where legality often masks immorality. And then all assert that healthcare is not a commodity, but a human right. We need to move beyond rhetoric to action. And your presence here today is a testament to the belief that it's possible and necessary. So as we engage the conversation today, remember that each of us holds a piece of the puzzle. No one person can do this. The needed transformation or reinvention of healthcare cannot be done by even just a small handful of people. Thus, the intent of our time together today is the first of conversations that Lonnie and I hope to do throughout this year. It's not just about envisioning the better future, it's about creating it with our hands, our hearts, and our minds. And so thank you for joining us today. I'm going to hand it to Lonnie while I start to create the breakout rooms. Lonnie, it's yours.
Thanks, Denise. As Denise creates the breakout rooms, let me tell you what to expect. Denise and I have crafted 2 questions for today's discussion. We're going to allow approximately 20 minutes for discussion on each of the questions. We're also going to closely monitor how much time each of the unmuted participants use, asking everyone to be mindful of the desire to hear from everybody. After 45 minutes into the meeting, Zoom will close the breakout rooms and we'll all come back together in this single forum. We'll close out our time together with a brief highlight or summary of key elements from each of the group's conversations. And then at the end of the first hour, we'll begin the speed networking breakouts for those who can stay. We are going to spend the extra 30 minutes having an opportunity for people to get to know some of the others who are with us today that they may not already know, or say hi again to people that they know and haven't talked to in a while. We will be sharing a recording of the meeting in the membership space of the PX community. We'll give you more details on that later. We're also going to share a summary with everyone who registered, regardless. If you're not connected with us on LinkedIn, meaning with Denise and I'm going to share our profiles in the chat, and also our our LinkedIn profiles and our email.
Well, and hi, this is Greta
Yeah.
Rosser speaking.
Hey,
I'll
Greta.
just say hi while you're busy making the rooms. I'll just say
Perfect.
hello to everyone. And it is so awesome to see faces and names that I only see in a static view on LinkedIn. So it's really cool to be with all of you, and especially so many of you who we like virtually connect from time to time. So I'm really grateful for this.
So the first question, we're looking at if we're going to solve the issues in healthcare, just this little teeny problem we have in healthcare, how do we move beyond just highlighting problems? Because there's a lot of that happening. We're really good about highlighting the issues. How do we move beyond highlighting the problems and working collaboratively on solutions? And if you have examples, I would love to hear them.
Oh, I'll go first, Denise. You know me, I don't have a problem talking. Um, I have an example I think that's very germane and goes along with the book Joshua and I wrote, Ripple of Change.
Mm.
And as a result of that, I've started to deliver a keynote called The Power of One Plus One. And the reality of the keynote is to highlight what can be done with really two people and how much of an impact it can create. I mean, if you think about what Joshua and I were able to accomplish as doctor and former patient, we feel like we've reached thousands of people and inspired many people at this point to play their part. In fact, I was going to write in the chat, I was thrilled to see how many change agents we had assembled here today. That warms my heart in and of itself. And so I think the key to these efforts is breaking down the silos and getting that synergy and then taking it to the next level. So I'll leave it at that to be mindful of time.
What a way to start us. Rosanna, I saw your hand up, and then Leslie, you're next.
Yeah, I'll piggyback off what Todd just said. And actually, what you mentioned, because really, I feel like we have, as you said, we have so much data, we have so much information, we have it. So how do we move the needle? And really, this idea of collaboration and partnerships and breaking down silos and movement, in my estimation, comes down to communication, right? Like clearly we have, and I would say then communicating the data, right? How do you compel that? Because we have so many people, and we've had this issue where we've had one or two people in an organization who are really responsible for communicating out patient experience data and really trying to push out people hitting targets. But it's not about hitting targets, right? Every row of data is a life, and I think that is where data storytelling can help move the needle, because that row of data is not just a row of numbers, it is a person. And I think that's part of owning not just key decision makers, but everybody. And you've heard me talk about data culture and really democratizing the data to where we can own the data and make decisions and not rely on somebody else setting the barometer for us to address. And it's key to have the right information. I mean, I was actually thinking, I have a little example that just came kind of related. When we entered this room, we were kind of unclear, some of us in this room, were we supposed to have our cameras off and mics off? And there were people who had that instruction. And then there were people like me who had the opposite instruction, right? Because I was like, no, we're supposed to have them on. So there was this confusion. And that was just a real idea of like our communication just in this context really threw us off. So we have to be really clear from the get-go what we're communicating and how and to what audience. And it's kind of a loosely related analogy, but our example, but one I just wanted to throw out there since we just experienced it.
And Rosanna, I'm just going to tag briefly on that to say, and how do we raise that so we learn from it? that we get constructive feedback and we don't go, oh, shame on me, but we say, oh, next time, how do I do this better? I think that's fabulous. Leslie, your hand's next, and then Heather, you're next.
I am going to build on both Todd and Rosanna. Someone recently said to me something like, how do you change the world? Well, one person at a time. And I think that there's so much truth in that. And I think speaking on the role of communication and kind of this concept of one person at a time, that there's so much value in conversation. And Denise, you and Lonnie bringing us all here together, that's a perfect example of bringing a group of people that share a common interest and passion on driving change and being the force and activating us. Another example, through the work that I do, we've created this, it's a story experience, really, where we take an audience through a journey of time in healthcare, a journey through the perspective of a human being in healthcare. But that journey ends with a cross-vertical conversation about how do we crush the complexity that's crushing us right now. So creating moments of bringing people together to in conversation is one. It's not the only thing that we need to do, but it's one thing building off of what we've talked about already.
I love that, Leslie. Heather, I'm going to pause for just a second, just identify that Audrey put a comment in here, and she said there's no failure, only feedback. And I love celebrating that. We need to risk that we're going to quote unquote fail and recognize that as, well, we stepped out and tried, and that's so valuable and absolutely critical. Heather, you're next.
One of the things that I see as a fundamental thing before this change really begins is how we create and specify safety for the people who will be impacted by this. Because people who work in billing and who work for insurance companies and who work through all of that paperwork that we find detrimental to the process, when they hear about universal healthcare, are first thinking about, how will I feed my children? And so if we don't build into the system ways to ensure that the people who dedicated their lives to some component of healthcare, whether it's bedside or back office, get the opportunity to still be safe as we move through it, we don't do anything to start to remove the individual barriers for the people who are going to be very frightened by a revolution.
Sue, I see. Heather, I thank you so much for that. Sue, I see your hands up.
Yeah, I love the question, Denise, about moving beyond highlighting the problem and getting to solutions. My roots are early on in my career in the area of quality, and I was in the area of I'm talking about 30 years ago, and I moved from quality assurance to TQM, CQI, and then now into high reliability. So I've seen this transition in the world of how we make improvements in healthcare, whether it's to create safer, more satisfying patient experiences, or any of the things we need to do to create a better healthcare system. But, fundamentally, we have to spend time understanding the problem and problem identification. But the issue that your question raises is we can't get stuck there, and we can't just go surface level and just see kind of the symptoms or the red flags of the problem. We have to understand it deep enough, but we have to have a process for how to do that well. And then how to take that learning and that understanding of what we know is the flaw or the opportunities, and then move that into proper process improvement. So I think, it's really there are very specific tools and methods and tactics that we can use for both problem identification and understanding and root cause analysis, and then proper tools to move into correction and fix. But we need boundaries around, we need knowledge around and understanding around not getting stuck or paralyzed or can't move through the process to fix. And I mean, we actually are always circling back to problem understanding and where it's at now. So we know where we're starting at, we understand it, then we move into some correction, and then we have to go back and look at it again and talk about it. And so it's this cycle we're going through, but the cycle gets messed up. People aren't quite sure how to navigate that cycle of improvement, and they get stuck in the awfulizing and, you know, talking about what's wrong, but maybe only at a surface level. They're stuck there even at a surface level, and that doesn't help you at all. So I really think it's fundamentally about those that are championing the local level change in particular and organization-wide change. There's just not enough skill set, knowledge set in the teams, in the individual leaders about how to shepherd problems to solutions and not just band-aid them, but fundamentally get to the flaw and find the fix.
So you just said about 10 things that I would love to respond to, and each one of those could be a webinar in its own. So I'm going to leave it there and hope that perhaps one of the others will grab a piece and go with it. And thank you for everything you shared. And Greta, I see your hand up. I will take this time to say Greta has volunteered to manage the chat for me as well. So she'll bring that forward if you add to the chat. But Greta, please.
Thank you. I've been in your shoes, Denise, many times, so I know how it's like to juggle all this. So I actually wanted to add right on to what Sue just said, and I was going to say it anyway, and it's perfect segue. We need a systems approach to improvement. It can't just be a really good altruistic person who wants to fix stuff, because they quickly become demoralized in our very broken systems. So it has to start here, and it has to happen here, and then we have to go like this. And, you know, I teach nurse leaders how to round constantly, and they love it when they learn how to do it. And yet they're up against a wall constantly, because whatever they find, many times they cannot fix, they're disempowered to fix. So we need a systems approach of support and failure analysis. I like what someone said, there's no failure. And while I'm at it, I'll say, David is saying, you know, we're looking at a bigger picture strategy. Absolutely. I think this is going to take an organizational level change that's consistent amongst organizations that are willing to be like the beta test and say we need to revert to an analysis of where the failures are and not waver. We need to just really focus. I'll say David is saying, you know, for which physical systems, but also systems of the mind. Yes, systems of the mind and the infrastructure in those systems. Because lots of people will tell you we need a systems approach, but do we have every single department on board and held to that standard? Very rare to find that.
Greta, I knew when you said systems that David would be sitting there going, oh yeah. I love it's, can we get beyond our fears and love each other and create the synergies necessary to change? I think we can. Hi, Emma, welcome. Emma said in chat, she's in Ireland. Oh my gosh, Denise, you have an international crowd. Okay. Nice. Excellent. Thank you, Greta. Thank you. And yes, David has, if you haven't followed him on LinkedIn, follow him. He definitely will help expand your awareness of the systemness. Leslie, I see your hands up.
Yeah, just a quick add-on. I think that there's different perspectives as well. So there's what we at Authentics calls the business side of healthcare, the paying for it, the financial, and then there's the clinical side of it. And so really kind of teasing apart what's broken within the different lenses of healthcare is going to be important as well as we think about the systems perspective.
And as I shared when we started this, the time's going to go by very fast. We're not going to be able to expand adequately. We're already going to transition to the second question, and we'll wrap up our brief breakout room with that. So the second question, so, and one of the things that Lonnie and I are really interested in is that creating that path forward. So how do we now do this? How do we build the transformation, build this collaboration? And we're talking pragmatically. How do we, not being overly lofty, but how do we actually do this? And John, we have not heard from you yet, and I wonder if you want to kick us off.
Sure. So it's kind of multiple tasks, to me.
Mm,
And the one thing that's been missing is, like I put in the chat, what are we trying to accomplish? What are the
mm.
goals of the vision we would have that would attract people to want to join? I think everybody here and probably millions of Americans understand that this profit-centered, whatever it is that we have in our healthcare,
Industrialized healthcare.
is not working for all of us. Obviously, we can do some things. We have some excellent centers of healthcare, but 40% of the country's basically been abandoned, and in a lot of areas in cities and stuff. So it is a systems level solution, I think. So the two tasks to me are, since it's going to require at some point political intervention, because that's the way our society works. If you can't approach it through the political process, the only way to do it is to garner enough movement, sort of like a tipping point agenda, to get enough support where you create your own political mass to be able to either go directly to the public or influence the legislators or voters. But again, it goes back to having a unifying vision, I think, of not just practice, but administration and financing and distribution of resources and public accountability. These are all things I think should be, in healthcare.
I'm not
Denise,
seeing,
there's lots
yeah.
of good comments in chat.
good.
John put, what do we really want to accomplish with all of this? And you just spoke to that, John. I'm just looking here. Audrey says we should connect. Okay, yes, let's connect, Audrey.
So I don't see hands raised. Any of you want to, oh, there we go. Sue, thank you. Go.
Well, again, like you said, there's not enough time to dig into all the
know.
solutions, but I'll offer up one maybe, and I ponder this. It's not to blame, it's not to cast, criticism necessarily, but just to point out opportunities. I have a master's degree in healthcare administration. I'm board certified in the American College of Healthcare Executives. And I know a lot of people that are, right there in the top levels of leadership in healthcare organizations. And they are leading organizations that are failing in these ways, yet they're educated and they're certified, right? So they should be the experts at being able to lead their organizations to deliver this kind of patient experience, even with the challenges of politics and finances and all of those resource things, right? I know organizations, organization A, organization B, reimburse the same way. Very similar community dynamics. One is top ranking, award-winning, safe, award-winning care, top ranking performance in all sorts of ways you can measure, and the other one failing. What's the difference, people, right? What is the difference? It is that system things, but somebody's got to know it and lead it, and it can't be single point of failure that when one person leaves, the whole system leaves, right? So like an organization I worked with, this is an example, 12 years ago, Critical Access Hospital, rural northern Michigan, failing, spiraling in all sorts of ways, financially, poor reputation, employee morale and the like. Now they're top ranking, award winning, top in the state. 12 years later, CEO turnover times 4. They just keep getting better. Built a new hospital, just built 2 new buildings on their campus, added jobs. What's the difference? They put in a system that's working and sustainable and growing and building long term. We need leaders that can do that. right? And I think fundamentally it starts with our education of executives that are leading these systems, and, healthcare providers, organizations, and, even our own board certification process for those of us that lead it. So like the credentials, when I see them, they're impressive, but I want to see the results of the organization they're leading. And that will tell me how much that education or degree did or didn't help. And I didn't learn it there. I learned it, but I didn't learn it there, I have to say, and they didn't learn it there either. So we've got to fix our systems for how we educate healthcare leaders, is a starting point.
And I won't say much. I will celebrate what you're saying. And I will say too often we defer to letters after a name and assume experience, expertise, competence. And I know very well that letters after a name are simply that. They're just letters. Leslie, I see your hands up.
I'll add on to Sue's focus on education, but I think there's an angle around educating the humans who are navigating healthcare, because they don't know how to navigate it. It's so complex, and we have an opportunity to be educators for them as well.
And Leslie, I love that, because yes, it's not just those who are within healthcare that own this problem. We are all part of this, patients inclusive of everyone else. So how do we all come together? Todd.
So I just wanted to maybe double click on what John had said, because I love some of the concepts in his work, and the paper he's written, I think, is brilliant regarding healthcare being a utility. I think to answer the question regarding what is the goal, I jokingly wrote, I want to boil the ocean, because I think there's issues top to bottom within our healthcare infrastructure. And there's not going to be one simple answer to this for sure. However, I've seen multiple endeavors in the recent past that speak to the power of numbers. For example, Tina Shaw's work in New Jersey regarding prior authorization reform, the challenging the maintenance of certification through Aaron Goodman's work on the West Coast from UC San Diego. And I think if we can have a platform or forum or network perhaps to consolidate the voices for change, we can start to move the needles in one area versus another. Another example, and I don't want to get too far into the weeds because it's not just public yet, has to do with taking advocacy to activism to get policy change related to mental health, suicide reduction, what have you. So the numbers are there, the people are there, a lot of great work being done all around the country. If we can start to unify those voices, I think it's going to be magical. So I'll stop there.
Excellent, Todd. John,
And
I see you.
Denise, I'm
yes.
sorry, I'll just say, Shauna brings up something related to that in the chat about this is about addressing the working conditions for the workforce. And there is a lot of policy and legislative work going on right now at that level. And that's where I really see us being able to make a change. So thank you, Shauna, for that comment.
Yes, thank you. And thank you, Greta. John, I see your hands up.
Yeah, I just want to talk a little bit more about what we mean by systems dysfunction. So it's not just we're talking about an individual facility here or there.
Right.
The major systems problem we have in this country is we have no system. We've got, individual profit centers, which are basically profiting on disease. They're not going into, primary care need areas because there's no money in it. Integrated, in my case, in my model, state-based integrated system. Oh, and by the way, thanks, Todd. These state-based integrated systems, since they're no longer competitive, can have a huge impact on the cost of healthcare by being able to negotiate together. And this has been something that's been missing. Title IX prohibits, for example, Medicare negotiating drug prices, but there's no provision that would stop a union of state-based regional systems from being able to negotiate drug prices. So whether it's equipment or whatever, MRI machines, it doesn't matter. So when I talk systems theory, I'm not just talking about facility management, but an actual national health system.
John, there was a comment. Heather would love access to your paper. Is that something that you could share perhaps within the chat here?
Yeah, you know what? I'll put my email address. Anybody that wants it, I'll be happy to send it.
Excellent. Thank you. And Sue, I see your hands up.
Yeah, I think that really speaks to the point of that it isn't just one system, it's multiple systems that are impacting each other and interfacing each other. And again, understanding the problems with each and how they're have a ripple effect and impact on others. One thing I would just say, as you know, being in the industry as a healthcare executive in a facility, or now a strategist, trainer, and coach to dozens of facilities, is that, you know, if we wait for some of those systems that are so friggin' long to change or may never change before we start right at the grassroots making things happen for our patients, you know, right at the clinic level, right at the doctor's office level where my husband's a primary care physician, you know, if we're not, you know, if we're waiting for some of these bigger things to change before we say, hey, we'll get to work making a difference for this one patient, then you know, more problems are going to just boil up and implode the system. So, you know, I think that solutions have to happen at every level and work has to be done at every level. And I think that whatever our sphere of influence or opportunities are, we should rise up and tackle them. So, and not maybe wait for somebody to come in and save us at, you know, those top levels. Yeah, I'm really cheering on those people that want to do that advocacy work at the top levels of, you know, financing and Medicare and da 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 da. But man, give me a facility that's failing at serving their community, and I'm going to rise up and I'm going to tackle it. And I'm not going to wait for some answer to come that's going to come from outside that to save them if I have an answer. So I just want to bring that point up, that it's many systems at many levels, and where we are, we can make a difference.
Yeah, and Heather, I'll come right to you. Two things to what you said, Sue. It's yes and, right? Yes, we need to tackle that, and we can't stop addressing the front lines now and helping, reaching out and helping them. Yeah. Heather.
So what I would kind of like to add on to this, especially because you get to the part where you're like, well, I can't make a small thing better because the problem is huge. I can't fix a huge thing because there's millions of us all burdened with our hopes and fears in various ways. One of the things that I have found most appealing is to watch this play out in other industries. And I'll use as my example, I subscribe to the Chronicle of Higher Education, which is the group of people who think about how universities in the United States work and behave. And universities are looking at a similar set of challenges. Our money comes from all kinds of different places. It's not as predictable as we would like. We have capacity problems and we've got the wrong capacity in the wrong places and all of that sort of stuff. And so when I think about healthcare, and very much to Sue's point, I see millions and millions of people. And when I read the the Chronicle of Higher Education, I see the flow of the systems differently because it's not my expertise. And so it's easier for me to watch how they think about things and where they're trying things and where they're getting a toehold. Because very much like healthcare in 2021 was like, oh my gosh, we need mental health support in the hospitals because we are all breaking in our own unique and special way. Higher education was doing that too, with about the same success that we had. But their evolution keeps on trying to find different ways to reach their kids and do that sort of thing. So I find it interesting when we get to how do we take action on a giant problem, to watch other industries facing that same giant problem, because I can see the flow and I can see the ways where we have blind spots as an industry even when we're trying to see everything.
Heather, two things to that, just briefly. One is, yes, we're so, if somebody's trying to talk with us who's outside of healthcare, we want to discount, you don't understand. But the problem is we need to have the insights and awareness of other industries. Where are we sharing complications, and how have they found solutions to things that we're already seeking to, right? That we're needing to solve and they've already done so. But the second thing, I was talking with a gal yesterday, and she made a good point that some of what we're going to need to do in order to change culture, society, systems is how do we educate those who are going to be the next generation? And how do we help them to be able to look at this and know, one, empower them. You can make a difference. And two, give them the tools and resources as they step into to be able to own and do, because we're going to need them all. And the youth often can bring some energy that some of us who've been here too long maybe don't have anymore. I don't know. Greta, I would love you to catch us up on the chat, because I'm sure there's been quite a bit going on there.
Yeah, well, you know, it came up about rural health centers and how those are some of our most fragile and vulnerable areas in the healthcare infrastructure. And also, Keely said that her group has put together 15 methods. And while we were chatting, I took a look at her website. So there's some neat, interesting things proposed there in the drawing room, as she calls it. But 136 rural hospitals have shut down, according to John. Thanks, John. And would welcome competent leadership, but even those that had it failed. And there are some also groups working on that right now, trying to bring those hospitals back to life, because it presents a care access and equity issue for individuals that are in marginalized communities who then their hospital shuts down, then they already were disadvantaged. Now they can't get care. So that's a really salient point here. So that's where we're at.
And I wonder if for a moment, because the question is, how do we, and I know that there's a few on the call and you've identified one, Keely, and then John and Todd, there are individuals who are working to unite groups and to step into some of this work. So I wonder, Todd, John, and Keely, and if anybody else also has solutions that you're already working on, which aren't just single point of person solutions, but are more of the let's bring people together solutions. If you'd like to take just a moment to highlight what those are.
Sure. Mine's pretty simple. I think everyone's heard of the triple aim and the quadruple aim, or at least I hope the majority of people have. In review, the quadruple aim is patient experience, quality care, lower cost, but also provider wellness. And in our book, Joshua and I talk about our quadruple aim because we feel like everybody needs to take ownership of the problems that exist and we all need to play our part to improve things. The reality of that simple lens is, though, when you take our quadruple aim and look at problems and use that as a guide to your solutions, the majority of stakeholders tend to thrive. And it tends to put people over profits. So if you want a simple tool, feel free to reach out to me. I love talking about this stuff. My wife's sick of hearing about the book, so I'd be glad to talk to somebody else.
Leslie, I see your hands up.
I'll add one thing that we've done is the work that we do is across verticals. So we work with pharma providers and payers. And one of the things that we've been focused on is bringing them together for purposes of conversation, which I mentioned earlier. But one of the anchors that we've been kind of rallying around is that a lot of the problems that customers have, patients have, caregivers have, pharmacists have, nurses have, that cause friction are process related. Because we see a lot of times that they just want to go to the people and say, oh, well, this is a person thing. We've got to change the people. And we're really pushing hard that no, it's a root, it's a process issue that is driving the friction and the care journey that needs to be fixed. So just one example of how we're trying to bring the verticals together to solve process related issues.
Leslie, I love the work that you and your group are doing. Thank you. John, do you want to share a little bit about Nurses Transforming Healthcare?
Well, first, because the question, yeah, okay. So the group Nurses Transforming Healthcare was a group I started with Kathleen Bartholomew and Kim Evans and Leanne Meyer, who's on here. And the intention of this group, because and I want to put some context to it, I did 2 internships in Washington. I worked with George Mason and Mary Wakefield's Health Policy Institute. I worked with a rep in Florida. I know there is like 0 pathways forward through the political system. They have just become so siloed, as Americans have, in the sense of how they think change could come. So in other words, they're aware of Medicare for all. We have, another vision of just ripping down the PPACA to go back to what? And then we have another vision of CMS type incrementally improving the PPACA, the value-based care scheme, this kind of stuff over the next 20 or 30 years in the hopes that it becomes kind of what we need. The 3 routes forward that I saw at NTH was getting a message of a coherent vision for what we're trying to do to, for example, doctors and nurses, because doctors and nurses together coming out saying, what we have isn't working, this is kind of what we need, would be a really powerful voice coming forward. We also need to reach out to business, because businesses in the United States are paying way too much money, $26,000 per employee for some of these corporations. States, for example, at the state level, a lot of state budgets are 20% goes to healthcare. So if we could propose a coherent model we could agree on, and move forward and make those arguments in those arenas. And then the other arm we had at NTH was trying to go public with a series of commercials, kind of effective domain commercials, that would pretty simply explain what a system that Americans already understand, which is public utilities, and to show them how it would impact their daily life, whether their daughter, got diabetes or their kid broke their arm or whatever the healthcare issue was. So that's kind of what NTH was trying to do.
Thank you, John. Keely, I see your hands up. Want to tell us about what you're doing?
Yeah, I'll do my best to be very brief. So John just piggybacked me into this beautifully. So we really firmly believe, as you do, that politics is not going to get us there on its own. However, I believe that the power is in the people. And like you were speaking to the point of, we have to educate the people through commercials, etc. So what we've done is we created the drawing room as a place for individuals like the people in this room to talk about it from a high level, but also to bring in the consumers, the patients and the caregivers, to be a part of that conversation, to show us our blind spots, so we can develop a comprehensive plan that addresses on a broad basis all of the different concerns, but through the lens of the solutions, not the problems. And so we propose the 15 solutions that you can get to easily if you go to the drawing room. I won't go through all of those, but with the mindset that they're movable, right? These are what I think, based on a lot of listening work, we should do, but we need more conversation in those silos, if you will, around the solutions, instead of in the silos of our different stakeholder groups, to come to the best plan. And then we push that to the people at large through a huge education movement. So I'm working with UNC Chapel Hill to try to get the young people excited about this and have them help us educate on the topic.
So we have just a few minutes left. Anybody else want to add to this? Sue, I'm curious, Sue and Leslie, others who work kind of across our nation, what types of things you might be seeing pockets of hope that others are doing?
Well, I'll start. I know it's just like a small pocket of the world and our country, but one organization at a time. When I'm working with small and rural organizations, we focus on less than 1,000 employees. So critical access hospitals, small clinics, ambulatory surgery centers, addiction centers, and the like. But they're small organizations. But when they're struggling, when they're not able to serve their mission and serve it well, when they're able to turn that around, I mean, that gives me hope. You know, John Cotter would say that transformational change, 70% of the time it will fail. Our success rates are well over 90%, the organizations we work with. So it should fail. Well, it should only succeed about 30% of the time, and we're hitting like 93+% of the time they're able to do this work. It's about 2 years worth of work, but I see what's on the other side of it. I see the formula that's working, and it gives me hope that every time we run that formula within a system, it keeps getting those results, like the scientific method. That gives me hope at a micro level, I guess. But to those communities, it's big. You know, it's not small to them. It's big when they don't lose their community hospital. It's big when their you know, access to care stays local. So that gives me hope. That gives me hope that there's solutions out there that actually work over and over again.
So I'm hitting the close on breakout rooms, which means we have 60 seconds. And actually, I think I'm seeing others joining us. So we should have 60 seconds. So Leslie, I saw your hand up, but I also see Todd's hand up.
Go ahead, Todd.
Oh, well, I
Fill
was
this
just
out.
going to offer some examples of hope. I think there's a few. I was talking with Melina Davis today from Virginia Medical Society and her work with Safe Haven. That's wonderful things. The Lorna Breen Foundation and their work on a large, you know, countrywide scale in terms of mental health access for frontline caregivers, what have you. You know, and obviously I'm partial to Medicine Forward and the work they're doing. So there are amazing, and just look at everybody in this room, right? Like everyone here is here because we want to see positive change. This experiment in and of itself to me says hope all over it.
Indeed. That's a fantastic way to close us out, Todd. It's the awareness of others who are doing really good work, and how do we start to join, not that we're all doing the same thing, but we're joining together and lifting each other up and finding those synergies in our efforts.
Welcome to everybody. If we've asked you in advance to unmute yourself so that you can speak as part of this conversation, please make sure you're unmuted. If not, please stay on mute, but please use the chat liberally. We'll try to respond, or at least we're capturing the comments and questions for follow-up. So we've got 2 topics for today. 20 minutes per topic is, you know, doesn't do either topic justice really, but we're trying to get some text around the conversation. We decided not to spend time in this meeting talking through what the myriad challenges are with our current healthcare system and model. I think most of the people who are participating in the meeting today are very familiar with those challenges and very often speak and or write about them. So we're trying to focus a little bit more on practical solutions. So the first question is, how do we move beyond the highlighting or the emphasis of what the problems are to a process where we can actively work on the solutions collaboratively? And I'd certainly invite those of you who are going to be speaking to share examples from your own experience if you have those. What we're trying to see is what is being done, or whether the people feel can or potentially should be done to foster more collaboration. And one of the reasons that we're putting it in that context is because we know there's a lot of efforts being made already and good initiatives around improving healthcare in some way, on fixing the things that everybody knows are broken. So what we're looking for here is, how do we look at a fresh way to approach it so that the different efforts, the different initiatives can inspire each other, can be known to each other, can potentially collaborate around common or shared solutions around these problems. So with that, among those in this group who were invited to unmute, who wants to lead off?
Being an expert, I will. Good afternoon. My name is Jen. And as I listened to you, Lonnie, the first thing that jumped into my mind is, so many times people try to solve the problem. And that's exactly what we're talking about. How do we move beyond? And I like to say, let's pause and let's look at the problem through the lens of appreciative inquiry. Let's really slow down and let's go through, the design, looking at dreaming. What do we want our future to be? Looking at having that dialogue of what it might take, and then looking at actually what is it going to take to design it. So really the discovery, the dreaming, the dialogue, and the design, and making sure that all players are at the table. That is critical. So many times we try to solve things in bubbles. So I'll just put that out there and start the conversation.
Well, it's a great opening. Thank you. And by the way, Robert, thank you for raising your virtual hand to be recognized, because one of the ways that I'll be able to help with the moderation is people who want to speak, you use that reaction field to raise your virtual hand, and you'll be recognized. And Jen, thanks for framing that issue so well. I also, before I recognize Robert, just want to briefly mention Michelle's comment in the chat here, where she says Denise and she have spoken briefly about strategic doing. And Michelle wants to know if any of you have worked on big, hairy problems using that strategic doing process. She says Peter says he's worked on several, but not specifically with that process. Robert, go ahead.
Yeah, I'd just like to tack on to what Jen was saying, that for those that don't know me, my expertise is in nurse staffing and nursing finance, which of course, the whole staffing and scheduling component is a huge part of the patient experience. And so my interest has been in trying to figure out, well, why are we having such problems with staffing and scheduling? And to understand this, we have to use data. We have to understand the problem before we can solve it. And one of the things that I've learned in my work on staffing and scheduling is we've actually got a lot of bad information that's being circulated out there with regards to staffing and scheduling. And some of this is even being promoted by some of our nursing leaders and nursing professional organizations. So, and that's been one of my challenges. They haven't been very receptive to hearing this information. I've got we've always done it this way in response to some of my approaches. But so, for example, with the nurse, staffing and scheduling problem, a lot of nursing departments think that they can solve this on their own. Even the big nursing professional organizations, they put together this big think tank of all of these other nursing professional organizations. I think there were 5 of them, to come together and brainstorm about how to solve staffing and scheduling. Well, nursing doesn't have all of the tools and expertise to do that. We need to find a way to bring together not just nursing, but also finance and HR, and I would argue even quality, to take a more data-driven approach to looking at, well, what's going on with our staffing and scheduling. And there's a way that I've been working on where you pull this data together. And for example, having these discussions about staffing and scheduling, you can look at the data in terms of FTEs or full-time equivalents, which makes sense to the finance people. But you can also talk about those same FTEs in terms of hours and shifts that makes much more sense to the clinical people. And so through this way, you can actually sort of develop a Rosetta Stone to help foster this collaboration, communication around staffing issues. So I guess that's kind of my long-winded way of saying that, we have to get to the data. We have to get to the right data. And we need to break out of our silos and not think that any one particular problem can be solved in one silo. With the number of professions and services that we have in healthcare, it's going to have to be cross-siloed and interdisciplinary approaches to solve many of these problems.
Robert, you make a great point, by the way, about silos in terms of the fact that there's internal collaboration opportunities within an organization as well as external collaboration among different organizations. So it's great context to add. Kathleen, you have your hand up.
Yes. So I think the question was what fosters collaboration. And first of all, I think that this event is one that fosters collaboration. But I love Jen's mention of not just discovery, but dreaming, because Carl Sandburg said nothing happens if not first a dream. And when you're on LinkedIn and when you're talking to individuals, I see problem after problem after problem. It's like outcome after outcome after outcome. It's like I'm actually have distanced myself because I follow Donna Bedian. It's structure dictates process, which dictates the outcome. And people are trying to improve the processes in many different ways. But the actual problem, our challenge is a structure. And it's because we built a structure where healthcare is a commodity. This is the foundation of healthcare. And I think that what has to shift, belief more than anything else, it's not about what we need to do, but is healthcare a commodity? I mean, is it ethical for so many millions of people to profit on disease and death? So the question that I think is, I mean, I think that healthcare is a service. It's a public service, and that everyone has the right to be well. And with that as the foundation, I think that together we could build something. How? Where do you even start? Well, Bucky Fuller said, you don't fight the existing system. And I see people trying to integrate into the system, work with the system, but that is not my that's not my dream. My dream is to take one zip code in America and to take all the people's call and to build a healthcare system in that one zip code that would be a template for how we would like the entire US to run. In quantum physics, that's called a holon. And when we look at complex adaptability theory, you don't change it from the top, you change it from the outskirts, and you change it by creating a model somewhere that works. And I'm just going to hold the belief that everybody that's on this call and is coming to the Healthcare Reinvention Collaborative has the talents and skills and knowledge and resources to create healthcare in one zip code.
So I'm familiar with what the work that you and John are doing around that as well, and I'll invite people who are not to check out Kathleen Bartholomew and John Silver and the work they're doing, and focusing on building a template is, I think, a really important facet of how this might be approached. Zev, you have your hand up.
Yeah, no, so I really enjoyed Jen's introduction of AI, the original AI, which is appreciative inquiry, not artificial intelligence. And I was trained in that a long, long time ago and use it often. And I think that this is such a huge, complex situation and set of challenges. And so the approach I started to take a number of years ago was to start to look outside of what I was doing in the traditional healthcare system and to use AI, use appreciative inquiry to find out where are those exceptions to the rule, where is the positive deviance happening in healthcare. And I was surprised even over 10 years ago when I started to do this very, very intentionally and seriously, calling one person after another who were creating, and I would say along Kathleen's line, not trying to solve the entire system, but really taking a piece of it, whether that was senior care or women's health, and coming up with new and different approaches. And I will say I continue to be just blown away by how much positivity there is out there, how much good is out there, how much success is already out there. And I think to Kathleen's point, the gestalt out there, is sort of a negative sense that we're heading in the wrong direction, everything's bad, and I think it's just you'll see what you point the flashlight at, and what I've been pointing the flashlight at in an appreciative inquiry way is those exceptions, those positive deviants, and I honestly don't have enough time in the day to identify and talk to all the people who are actually creating a new healthcare. And I can, I think I've seen some of their approaches. I've tried to figure out, sort of they use the methods they use, but I think there are lots of different methods that are, many of them or some of them have already been mentioned here in this chat. But I think that there's lots of different ways to tools to use, the methods to use, and there's lots of examples of how we can actually change the system. I think what's required is a bit of scaling, but I'm happy to sort of go into there are probably 2 or 3 major lessons I've learned and takeaways I've learned that I could share as well. But I think the AI approach, the appreciative approach, is really a powerful one.
For those, I mean, this is not a plug, but it is a plug. Those of you who have not yet read either of Zev Neuwirth's incredible books, Reframing Healthcare and Beyond the Walls, he shares a lot of these, not only these ideas, but a lot of initiatives that are underway around these ideas. So really appreciate your participation in this too. I don't know how you have the time either, but glad you're carving out a little bit of it for this conversation as well. Jen, you had your hand up again, but you're on mute, I think.
I am, because I'm so afraid my dogs are going to start barking. So I apologize. I sit here and I'm going to stir the pot a little bit. And I think to stir the pot. I sit here and I look at the screen, and I looked at the screen when all of us were together, and I was listening to Robert with, staffing and scheduling. I'm a nurse too, Robert, so I can, relate to all that. I'm sure there are other nurses on the line. But I would ask the question, who's a clinical nurse? Who's the end user? Who's the person that touches the patient on this call? And are we sitting in seats where we can make a difference, yet we're not engaging the people that are going to have to operationalize the end product. And I'm a proponent of professional governance, shared decision, whatever you want to call it. But I believe that we have to engage our bedside clinic, stretcher side colleagues in order to make sure that the plan that we come up with is going to work for them. Because if it doesn't work for them, we've wasted our time. So
that was a really good observation. Looks like Mick, go ahead.
Couldn't find the hand button. I'm not sure where.
So
my real. Yeah, no, I think this is great. I mean, I as a serial change, I think one of our challenges is that we tend to focus on failure as opposed to success. So I think to Zeth's point, there is a lot of success out there, and we tend to all think we can go fix a problem rather than replicate success. And I think that's one of the biggest hindrances we have right now is people are saying, hey, if I have this widget, this gadget, this gizmo, I can fix something, when in reality, somebody's probably already out there and fixed it. If we just went and learned from them and identified success and replicated success, it would be much easier. There's a great book, if folks haven't read it, called Switch by the Heath. I think it's Dan Heath. And one of the examples he gives is how would you cure, starvation? Would you go to the first group and try to, feed them better, figure out something, or would you go to Africa and find the group that's actually surviving well and see what they're doing differently from everybody else and scale that? That would probably be a better approach. And I think in healthcare, we have far too much of the, hey, I can solve the problem. And it typically is a workaround because you don't understand all the perceptions and things like that. It'd be a lot better to solve things if we could go find people that are actually succeeding and replicate it. So that's my 2 cents.
That's actually a perfect transition into the second question. Which is how do we actually build transformation or an acceleration model, if you want to think of it that way, around all the efforts that are being activated already? Because a lot of what is happening, we know what we're working on, or we know maybe what other people we're close to may be working on, but we don't know what we don't know. So we don't necessarily have an insight into some other people, groups, initiatives that are working on the same problem that may be going down a similar path and are further along, or just have something that we can extract or collaborate around to accelerate the level of progress. So that's really the second question. Now, Brad, I saw you raise your hand. I don't know if it was in response to the first part of the conversation or this next part, but feel free to chime in.
It may tie into both. I think Jen said it incredibly well. It's always like, where do we always start with design problems, right? Is really at the problem. And there was something that Mick just said that really struck a chord, sort of combined with what I've read in Zev's books. There's an interesting model that a lot of people have reached out to recently around the adoption of electricity to understand the adoption of artificial intelligence. And one sort of story or pattern that I really like in there is, how did manufacturing change with the adoption of electricity? And there's actually 3 different layers to it. There's sort of like the spot changes that they made, meaning all of a sudden they realized, oh, you could put, an electric fan over top of a workstation, right? And that would clear out the air a little bit, solve the small problem. Or you could stick an electric lamp and a little bit more light to a worker's workstation. However, it was still, everything was still steam powered. All the central really functioning of the factory was still very much steam powered. And then you had application level changes, innovations, and that was where you started getting into full out, transformation to electric engines that would dramatically improve the cleanliness, say, or various aspects of someone's workstation within a factory. But that was actually really challenging to apply in practice, because actually it implied a lot of cost on manufacturing to really change out this model and now run wires and do all these very practical things you needed to actually take advantage of this now amazing invention of this electric motor, and how it could make and so it didn't actually click until people actually not way later, but it was a couple of decades after really that electricity started coming onto the scene, that they started moving into a systemic innovation. And they started understanding that, hang on a second, if we actually now that we can run wires to use these motors, we can rethink the entire formation of the factory floor. We don't have to put everybody on these central columns because everything's coming off one steam pipe, and so then they started to like pull everything apart, and that really led to a dramatic shift, and also a significant lowering of the cost of manufacturing in a very interesting. So the spot application did not actually bring down the cost of manufacturing significantly. The application levels, like changing out the motor and stuff, that also did not actually bring down the cost. It wasn't really until systemic rethinking of the entire manufacturing line. And ultimately, what then Mick's thought brought up in me is, my background is, I come from the outside, right? I'm like the tech guy. I got dragged into healthcare when we were working. I helped build Unite Us, which is a platform that connects healthcare with social care. And we really got pulled in the back door of healthcare, and then ended up working with some of the largest healthcare brands in the country. But one of the lessons I've always brought in from tech, as we think about products, is, go to like the base outcome and really start there, right? Like, what is the core? And I'll use Uber as an example. Maybe two tech give you a thing, but if you think about it, the problem was not like, how do we build a better app to, call a taxi? There was actually tons of people that tried that, and none of them worked. It was really getting down to like, what was the core problem? It was like, I'm standing on a street corner and I want to ride, and it's nearly like, it's this, somebody else may know the example here, but there's this practice that we use in thinking through product ideas and designing product ideas of like, go up a layer in the root of like, what's really, just like Jen was just saying, right? Like, what is the core experience of the nurse, right? What is the core experience of the interaction between a nurse and a patient that really wants to become the focal point of the entire design practice of the really that we're trying to then, build everything around. And rather than focusing on, I need a better nail so I can hang this photo on my wall, right? It's like, well, hang on a second. What do I really want to do? Maybe I want to, I can solve that problem in countless different ways. Maybe I need a better drill so I can drill a bigger hole. Or maybe like 3M, you come along, you realize like, no, actually, they don't care about drilling a hole. You can innovate all you want in the drill and in the hole and make that cheaper and everything. But no, they just want this little like sticky tape thing that holds enough weight to hold a picture to the wall, And it's like, we sort of call that like the chain of outcomes. And it really gets down to, I think, what Jen said. It's like, what is the core outcome? All of you have way more experience in this than I do. But I think it'd be interesting. Like, what is that core outcome that sort of we feel like is, the heart of optimizing around, and that everything else needs to orient around that experience.
It's a really good point. It's you're kind of speaking to the concept of reinvention or rethinking, or both, rather than just modifying the existing level. So I appreciate that input. Anybody else? We're just thinking about how to construct something that actually connects all these dots, connects all these players, informs everyone, facilitates a greater opportunities for collaboration or advancement. And everything I've heard so far is fantastic. And I'm not even having an opportunity, apologies, to read some of the comments in the chat during this conversation. But I don't want to do too much talking. So please, who else would like to weigh in? Mick, you wanted to say something?
Yeah, I'll just follow up on my, I think the last comment, and, one of the challenges we have is we want to replicate success. The other challenge we have is we need to define what success is, right? So if we actually if we could agree on what the outcomes are that we want, we might have a better job of success. But between the worlds of mission and margin, it often gets lost, right? You see more on LinkedIn about people raising money and defining that as success, or EBITDA as success, versus what are the best outcomes? What are the, what's patient-centered? How did we promote continuity and the likes? I think it's replicate success, but I think we have to do a better job collectively of defining what really success looks like in our healthcare system.
And the different definitions or different perspectives on how they define success, I'm sure. Bruce, did you want to, you put it in the chat, but did you want to comment a little bit on your chat comment about taking care of patients and taking care of people who take care of the patients? Sorry to put you on the spot there.
Huh?
Didn't mean to put you on the spot there when you were off camera, but
oh no, that's okay. I thought it was self-explanatory. I mean, I'm also simply thinking of the amount of burnout and chronic stress that's going on in healthcare and among healthcare professionals, and moral injury because healthcare organizations are not taking care of healthcare professionals, nor are they seeking their input oftentimes in really how to do a better job of taking care of patients. So.
Okay, thank you. We have a lot of hands up here, and I don't know how many people who have their virtual hands raised forgot to turn it off or raised it again. So I'll go back to Jen. Go ahead.
I want to go back to what Mick said, and I agree. We've got to define what success looks like, yet know that success looks different for each and every one of us on this call today. And we have to make sure that we understand that. You know, when I talk to people about quality, quality looks different. Now, what's quality care? What's good patient care? It looks very different to somebody in the lab who's getting messed up lab, blood cultures sent down to them versus, the patient who just got stuck 4 times to get an IV in. So again, what is success? I think that's a good AI question to start with. Really, what could success look like? And I know in one of the workshops, the company that I lead is also known as the relationship-based care company, and we do a lot of AI. And when we meet with people, we ask 2 specific questions when we meet with staff. The first one would be, what would the perfect patient experience look like to you? And then the second question is, what would the perfect work day look like for you? Because again, their work day and the perfect patient experience may be in total different directions. So it's going back to the using AI, really looking at what does success mean to an individual, because it's all different.
Just real quick, Sally, I saw your question about whether we're looking for feedback from just the people who have been invited to speak or from everyone. And we want everybody's feedback. It's just the time management issue here. So one thing that I would just want to step back for one moment and clarify is, number one, this is the first conversation in this particular type of forum. It isn't going to be the only or the last one. And secondly, be collecting feedback asynchronously on an ongoing basis. So if we don't get a chance to recognize some of the people who are here on the call who have something they'd like to add today, I apologize in advance for the time management constraints, but we do want the participation. We absolutely want it. So Kathleen, did you have your hand up again? Oh, if you did, you're on mute again.
Okay, sorry. Yeah, I just what's given me hope is that we did a pilot project, and you were saying what's the outcome, and to us the outcome was the perception of a person cared for and decreased visits to the emergency room and increased health. I mean, I think those are some basic foundational things that we all want. We want the trajectory of health and disease in America, where we're getting sicker every year, to stop and go the other way towards wellness and prevention. And I think that, the structure that we have, the business, that's what I'm saying, the structure is designed so that even this conversation, all the words like mission and margin and fixing and the terminology that we use, we don't even understand, is still grounded in the old system. For example, I mean, in our, what do I charge in this new system that I have created for connection? And is there a price for caring, or for, visiting the older person that you had moved to a skilled nursing facility, and giving him a present? I mean, there's, here I've created this little virtual world in a pilot project, but that there are no billing codes for, I would say, at least half of the things that we're doing. So to me, it's even being aware that our own language is still based in the old structure, and to use our imagination and to say what would success look like if you just had a small geographical area, to start that dialogue and make it very visceral for all of us, and say, what would it look like? Let's have a conversation. Just if we had one town in America where we could lead care, what would that look like? How can we take the best of what we all do and put it into one place? It's just an idea.
It's a really good point. And I also noticed that in the chat, there are several people who've commented on one of the, the things that they would do first is kind of flip the pyramid, I guess is one way to describe it, and put primary care more in the front of the prioritization of care, which, there's a lot of people working in primary care, but there's still a lot of fragmented handoffs or other kinds of issues around who gets to clarify what the challenges are with the patient and how to address them. Zaf, you had your hand up again, and then Robert.
Yeah, I think Robert was first.
Okay, Robert, go ahead.
Thanks, Lonnie. Thanks, Zaf. Yeah, I wanted to circle back to what Bruce was talking about how we should be taking care of the healthcare professionals. And I see this as one of the biggest problems we have in the industry right now. For example, if you look at nursing, the key metric that they use to determine whether you're doing a good job or not with your nursing department is productivity, where you're looking at the number of hours that you have had, budget appropriate hours that you were supposed to have for the volume of patients that you had versus what you actually scheduled. This focus on patient care is actually one of the biggest problems we have in healthcare today, because it neglects. We've spent decades trying to apply lean methodologies to nursing care to make it more and more efficient. And in doing that, that's largely driven because we're looking at some sort of outcome. It's driven by outcomes. We've got poor patient outcomes, we've got falls, we've got poor financial outcomes, whatever. So the focus is always back on the patient care component. That patient care productivity focused neglects the things like time off, which we need to give to our employees so they don't burn out, and education that we need to provide all of this orientation and to maintain the competency of our workforce. And through the work that I've been doing on what I call care-centric mathematical modeling, we can actually take budgets and calculate, okay, how much do you need for patient care? And then what do you have left over for what you need to take care of your staff? And through that modeling, we can actually demonstrate that as our available resources for time off and education decrease, so does our capacity for providing safe and effective patient care. Because at that point, you're not giving your staff your time that they need. You're probably working them overtime because you don't have enough resources. Likewise, you're unable to provide the education. And we've actually got, I've actually seen data where that available resources number is actually negative, which means that before that nurse manager even grants their first time off request, you're already short-staffed for what you need for your baseline staffing for your average budgeted average daily census. And these concepts are some of the things that so many nursing leaders are just not even aware of. And that, yes, we need to look at, well, how do we improve patient care? How do we get the resources of that? But we can't take that narrow productivity approach and think only about the patient care component. If we're going to solve these problems, we need to ensure that we have an adequate number of resources for patient care, plus an adequate number of resources to provide time off to these employees so they don't get burned out, so they're not working tons of overtime, plus additional added resources so that we can provide coverage for orientation and education. Because, I mean, we know that with the increased turnover, orientation is getting to be a big expense for a lot of these facilities. And that educational component is so important for giving these new graduates, effective orientation so that they can be competent, when they get in the bed. And it's a huge issue for patient safety and positive patient outcomes.
Thanks, Robert. I obviously work very closely with it, so appreciate your perspective on all of that. Zeb, go ahead.
Yeah, there's so much to obviously say here. I think, when you step back here, there's so many different aspects and components to healthcare, and there's so many different needs. So if you ask me what the ideal patient experience is, I would have to tell you it really depends on what the problem is that I'm facing today. So if I've got a migraine, my experience is going to be different than if I, was just in an accident or a hip replacement. And so, or, if I'm, trying to take care of my 86-year-old father, that experience is really different. So I think that what we do need is to have multiple modalities, and and I'm grateful that there are so many people out there working at all these different patient experiences and patient challenges and circumstances. So I think it's that's what I'm hearing in this conversation too, is we're moving from what Kathleen was talking about, which is sort of a community type of care to what we were just hearing from Robert at the transformation. And I hear that in a lot of what people are saying. No matter what the circumstance, what the need, what the job to be done is, the human experience transformation, and that does include the experience of providers and healthcare staff. The second transformation is the digital transformation. And I think it's unlike anything that we've actually ever seen before. And there is nothing in my mind that's going to happen in healthcare that isn't going to require the digital transformation. And that would be everything that is happening now. And the third transformation is the business model transformation, which again, I hear a lot of people saying there isn't. I would challenge anyone to come up with any solution that is going to be sustainable for the future that doesn't require all those three of those things. And what's remarkable is, and I think what's hopeful, is that there isn't any precedent for any one of those things. We've never seen the human experience transformation in the way we're seeing it now. We've never seen the digital transformation, and we've never seen the business model transformation. 10, 12 years ago, the platform business model did not exist. 10, 12 years ago, the digital transformation didn't exist. And even about the closest I could come. But I do think those are the three that are going to be required no matter what problem in healthcare you're solving, for whom you're solving it, under what circumstances. I can't imagine you'll be successful unless those three are part of your formula, are part of your strategy.
I just thank you, Zev. I suspect that within the next few minutes, we'll find ourselves bounced back into the joint main meeting room. So if somebody's speaking when that gets interrupted and we flow back in to be together, hang there with us, and we'll make sure we're getting a good wrap up and talking about where we go from here, because this is a fantastic conversation. Brad, you had your hand up again. Oh, I'm sorry, Peter, you haven't had a chance to speak. Go ahead.
Yeah, and thank you for helping me figure out how to raise a hand. I feel very embarrassed because I'm a techie and I go, what the heck is the user interface on this thing? It's ridiculous. So and this is not a product pitch. This is just work experience that I was asked to do to solve a problem. And Zev, you just nailed all of the key components. In 2014, I was approached by Kaiser, and they came to me with a simple problem: build a new precision mobile care delivery strategy that scaled down to a single individual, incorporated all elements of the social determinants of health, and also had a profitable business model. And it took me 4 years, and I figured it out. And we got everybody, all the kind of people who are in this room right now, and we built the demo. We got everybody to sign off on it, and everybody loved it. And it included a new mobile healthcare super app, something that scaled down to an individual and adapted to them. So when you talk about human-centric events, we got it down to every aspect that the individual wanted to change about that experience could be incorporated in real time. So the app was adapting on the fly in real time. And we built a financial model too. We used Kaiser's KPIs and all of their numbers, and we showed them a $2 billion saving on just 2 comorbidities in the first year of using the technology. And we actually thought, and we didn't even go after the revenue side. We actually had it built another model for revenue as well, tied into your SDOH and into other ecosystems that would also pull in. And we thought, we're golden here. And you know what? The guy sat in the room and he raised his hand and said, who cares? And it was my biggest mistake. I went, oh my God, I never got buy-in from the C-suite. But literally, we have a bill. It's all online. Everything is available. It was all being validated by Kaiser. And it was the first of its kind super app that actually totally engaged the patient on a minute-by-minute basis. It had the privacy built in. It had the security built in, everything that you would want. And it starts with the patient. And the patient says, how am I feeling today? And even to the doc who was tracking me and called me and said, you haven't done enough steps today. And I go, how the heck did you know that? And I realized that we built this engagement solution. I thought this was a shoo-in. And I would write a license right now for free. If someone wants to use this technology, I will do it. It's on being recorded. And for Kathleen, there's your zip code. And I go, you can do it. You can engage. We did. We scaled it down from 1 person to 12 million. And the technology is designed to scale to billions of people. And it would incorporate everything that everybody is talking about here today, especially Zev, what you just said, those 3 components. I knew nothing about that when I started healthcare. A lot now, which it's not much fun. So, but it's all there. It's doable. You just have to have the will to do it, the will to change.
Well, Zev is asking the chat, why didn't they want it at the C-suite?
Yep, it's simple. You know what? It blew me away. They didn't want to change their business model.
Right.
I said, you're kidding me.
Right.
I said, you've got patients who are getting better.
Yeah.
The docs signed off it, the clinicians, like psychologists, the IT people, and the C-suite went, well, no, I don't think so. We like our business model right now.
Yeah. So Peter,
and I am seeing that everybody has joined us now. And Lonnie, I'm trying to find you in among everyone.
I'm here.
Hey there. How did your group go?
It was fantastic. I can't believe you interrupted us right in the middle of all this amazing, creative, transformational discussion. Really good. Unfortunately, my recorder left and went back to your room about 7 or 8 minutes ago. And
I kept trying to shoot him back, but he wouldn't
Yeah,
go.
I don't know. I can't believe he would leave my room, my own recorder. Anyway, it's a great conversation. A lot of really good insights about the fundamental requirements of making change, which I think is ultimately where you have to start. So I think everybody who participated, including those who were just participating in the chat, had great input, and everybody was, picking up on the comments of the other people. So it was great. It's just way too short.
Yeah. Lonnie, I felt the same way. We had so many different items identified. There were times I think I told Sue at one point in what she shared in just a little brief section, there were like 10 items that I would love to go further on. So I'm looking forward to re-listening to the recording. I know at least this side was recorded, and being able to pull out some of those threads for future conversations. And with that, we'll let you know the next step. So this is just the first of these conversations that we want to have this year. What we're hoping, though, is that these are not just conversations, but that we find ways of connecting people in action. So not necessarily that Lonnie and I are going to facilitate a tangible action, though we would be happy to do that, but that we can say, hey, Sue, you should connect with so-and-so, and you've shared this conversation and you've identified that yourself, and that these connections start to happen so that this work can move forward. So we do have the chat from here. I will be pulling that chat together. Lots of people shared their contact information. I'll share that out with the summary email that goes out. So you will get a summary email that tries its best to give a summary of all of this that was shared, and there was so much. There will be, I will do my very best to see if I can gather some snippets of really key things that were said. And as long as that individual approves doing so, we will share those more broadly here and hopefully on LinkedIn or other areas, get that conversation going. And we will continue these conversations. There is a panel already scheduled in April that Todd and John and Zev, and I think we're just missing one of those others they will be on that panel
Adrian,
with us. Adrian, yeah, she's not here with us today, but we'll have that panel conversation. Lonnie and I have put on our calendars the conversation for March. And of this conversation, you're going to get a survey post, and it's going to ask you what topic should be next. So please give us an idea of what we should be talking about in March and in events throughout the year, and we will continue the conversation with the right
Also,
people.
if I can just add one other point
Yeah.
before we break out of this one.
Yeah.
We do have a new website up. It's, the first iteration, but it does have a join us page where you can give us your email, and we can make sure that you remain in the conversation if you're interested in doing that for future events, updates, initiatives, etc. So that's healthcarereinvention.com. And just drop us an email address, and we'll be sure you're included.